Hello everyone, and welcome to a rather comprehensive view of cardiac pharmacology, as well as a little bit of physiology and a little pathophysiology. So in order to understand cardiac pharm, or cardiac in general, it's really important to go back and review your anatomy and physiology. You need to understand the path of the red blood cell through the heart, that it's going to go from the right side into the lungs. So when we talk about pulmonary emboli, and then from the lungs, oxygenated blood returns to the left ventricle and out to the body through the aorta. So I always say it's good to be able to follow the path of one erythrocyte throughout the entire body so that you get a sense of how the blood is flowing in the cardiovascular system. That's the one part of cardiac pharm. The other part of the cardiac pharm is the cardiac control center. So it's the part of the brain that's controlling the blood pressure, the heart rate, and how we perfuse things. Located in the medulla of the brain, and it's regulated by baroreceptors in the aortic arch. They're going to sense changes in pressure, also in the carotid bodies. And with the change in blood pressure, it's either going to stimulate the sympathetic nervous system to raise the heart rate, or the parasympathetic nervous system to decrease the heart rate. So before we get into this slide, let's take a quick look at your sympathetic nervous system. Okay, and this is a very oversimplified sympathetic nervous system. If you have this printed out, you can fill it out with me. Okay, what we have over here is the spinal cord. Okay, it kind of is what it is. Sorry. And we'll move on from there. They have preganglionic neurons, and the neurotransmitter between them is acetylcholine. Postganglionic presynaptic neurons, and your main neurotransmitter there is norepinephrine. At the receptor sites, there's going to be 4 different receptors. There's going to be alpha 1, alpha 2, beta 1, and beta 2. Alpha 1 receptors are located in all sympathetic target organs except the heart. So this is going to be your blood vessels. And the main thing for you to think about is when the alpha 1 is stimulated, you're going to have vasoconstriction. When alpha 2 is stimulated, now alpha 2 is located over in the presynaptic terminal. When alpha 2 is stimulated, it's actually going to inhibit norepinephrine. Beta 1, located over here, is located in the heart and the kidneys. Beta 1 is going to increase the heart rate. And increase the force of contraction. And stimulate the release of renin. Let's move beta 2 down a little bit here. So beta 1 does a lot. A lot of things happening with your beta 1 receptors. Remember, you got 1 heart, 2 lungs. Beta 2 receptors are located in the lungs. And their primary job is going to be to inhibit smooth muscle or bronchodilate. So that's kind of an oversimplified view of the sympathetic nervous system. The reason that it's important is we look at things like beta blockers and alpha blockers when we're looking at taking care of patients with cardiac disorders. The better that you understand this, especially these effects, the better you'll know what to do when you're blocking these things. Okay, back to our previously scheduled program. So some other things that can stimulate the sympathetic nervous system, besides just your baroreceptors that are located in the carotid and aortic bodies, are things like fever. And you know, with fever, your metabolic rate will increase. Increased environmental temperatures will stimulate your sympathetic nervous system. You'll start sweating, trying to get some of your temperature down. Exertion or exercise, as your body demands more oxygen, the sympathetic nervous system will be stimulated in order to get more oxygen to the tissues. Smoking, because of the nicotine is going to cause stimulation of the sympathetic nervous system. That's why when people smoke, they get that kind of little nicotine high or that little nicotine energy push from having a cigarette. Stress response, and I know you know nothing about the stress response. There's this thing called the fight or flight response that if your patient suddenly passes out and falls, or I walk into class and say, let's just have a big old quiz and it's going to be like 60% of your course grade, your sympathetic nervous system is probably going to start firing and you're going to start getting tachycardic, hypertensive, your respiratory rate's going to increase because your body's going to demand a whole lot more energy to fight with me about taking 60% of your final grade quiz. So we won't do that. Pregnancy can stimulate the sympathetic nervous system, and pain. So a lot of times when people are not able to verbalize pain, we look at nonverbal signals, and some of those things are things like increased heart rate, increased respiratory rate, and increased blood pressure. They're all nonverbal indicators of pain. If they're going up, patient's not able to tell you, it could be that that's what you're looking at as a pain response. So that's your cardiac physiology. And like I said, the better that you understand alpha and beta and what happens when you block them, the better you're going to understand these medications. Then you have to remember all the different nuances of each medication. So no biggie, right? Okay. So we started off with perfusion with hyperlipidemia. So we're kind of taking away from the nervous system for a second, and we'll be back very shortly. They found a while back that the incidence of death due to cardiovascular disease is declining. Although it's still at top of the list, they found that when they started looking at fat content in food, it brought about a nutritional revolution in an attempt to lower lipid levels and improve cardiovascular health. Now, atherosclerotic plaque is not all fat. Okay, it's usually a very complex lesion. There's a lot of inflammatory mediators that go into it. There's calcification. There's blood cells. So it's not just lipids, but lipids are a large part in the development of atherosclerotic plaque. And you know, if this plaque develops to the point that it obstructs circulation, you're going to end up with a hypoxic heart, and nobody wants a hypoxic heart. Lipoproteins, this is just a review. They're not soluble in plasma, so they're carried by proteins. And the HDL is your good one. We went over this. It transports cholesterol away from the blood and back to the liver for destruction and removal. So we like the HDL. The more HDL you have, the better. I had a physician say once that an HDL greater than 60 was actually considered cardioprotective. So everybody get out there, get some exercise, and take some omega-3 fatty acids, and let's get our HDLs up there. LDL is your bad cholesterol. And it takes the cholesterol that's formed in the liver and takes it back out to the tissues and organs, because you got to have your yin and yang. It contributes to plaque deposits in coronary artery disease. And then you've got your VLDL, which is basically the carrier of triglycerides. Nobody really talks a whole lot about it. You'll every once in a while see someone that has their major problem is hypertriglyceridemia. I think that's a word. And we'll talk about one of the medications. As far as for NUR 200, we focused on statins and niacin, and that's what I want you to continue to focus on. I'm giving you an overview just to kind of let you know that there's other stuff out there. Okay, we talked about your target levels. You want your total cholesterol below 100, or 200, sorry. 100 is not really feasible. LDL, ideally below 100. And triglycerides, less than 150. So, treatment for hyperlipidemia. There's drug therapy that's going to lower your total serum cholesterol, your LDL, your VLDL. And there's 5 classes. The HMG-CoA reductase inhibitors are your statins. We just like to call them statins because it's a whole lot easier. Okay, there's biobinding acids, nicotinic acid, which you all know as niacin, and then we'll touch on fibric acid agents, and cholesterol absorption inhibitors. Then I'll take a break. So, to raise your HDL, because that's the good stuff, exercise. The first time I had a lipid panel, I was working out every day, and my HDL was 64. I held on to that 64 for years until I realized that that's not how it works. Weight loss, stopping smoking, watching those trans fats, a lot of the processed foods, fiber, omega-3s, and in postmenopausal women, they've seen that calcium supplementation can increase your HDL levels. Please don't ask me why. It's not on the top of my brain right now, but okay, your statins. also known as the HMG-CoA's reductase inhibitors. I would not ask you that on a test. I'd ask you about a statin. A prototype is simply kind of the example drug, right? And I've said in class, anything that has statin in the end is a statin. So atorvastatin or Lipitor is kind of your go-to prototype or example. It inhibits HMG-CoA reductase. Basically, it inhibits the production of cholesterol and LDL in the liver. So it's going to reduce your serum lipid levels, especially the LDL. However, there are adverse effects. Headache and fatigue. We talked about the muscle and joint pain, and if you start having the muscle and joint pain, you have to be on the watch for rhabdomyolysis, which is acute breakdown of muscle tissue. Statins interfere with cholesterol synthesis in the liver, and they're first drug of choice to reduce blood lipid levels. Right? Some of your brand names are Mevacor, Crestor, Zocor, Pravachol, and you need to take it at night. And we discussed that in class. There's some research looking into using it for slowing of dementia. Have not seen that research, but it's out there. With statins, you're monitoring your liver function test because it works in the liver. You need baseline values prior to. Monitoring for muscle and joint pain, and if a patient starts complaining of that, you need to get CK levels. So if they're coming symptomatic, and oftentimes they'll take them off the statin. Make sure they're not having GI symptoms. The way you can tell an effectiveness of a drug is going back to why you gave it. So if we're putting them on statins for increased LDLs or increased cholesterol, you need to go back and repeat lipid levels to see if it's been effective. Watch your macrolide antibiotics for an interaction and avoid grapefruit juice. One thing to think about, and it's almost one of those things you have to kind of Google and commit to memory, are the things that interact with grapefruit juice. Okay, statins are one of the things you cannot take with grapefruit juice because it interferes with the metabolism in the liver. There's some other ones which are not on the top of my head right now, but it's a good thing to look up because you never know when someone's going to throw grapefruit juice at you in a question. Real quickly, bile-acid sequestrants. These are things that you take PO. It looks like Metamucil, and it works in the gut to try and bind with bile acids and decrease the amount of cholesterol that you absorb. Rarely see this in acute care. A lot of times you may see it in long-term care. The problem is because it's working in the gut, you worry about bloating and constipation. It's really not a pleasant drug to give just because it mixes up. It's kind of this thick, viscous, orangey-looking stuff. Niacin. Okay, niacin is something that we talked about in class, okay, also known as vitamin B2 or nicotinic acid. Primary use is to reduce triglycerides and increase HDL. And your adverse effects are flushing and hot flashes. Right? You also can have some GI effects like nausea. For the most part, you teach the patient about avoiding flushing by taking it with an aspirin, pursuing a non-flushing formulation of nicotinic acid. Okay. For people that have that high triglyceride level, they'll put them on something called a fibric acid derivative or fibric acid agent like gemfibrozil, also known as Lipid. I have not seen it. Every once in a while you get a patient that takes this, and it's for treating severe hypertriglyceridemia. I was correct, it is a word. Right? Adverse effects can be GI distress, like most medications. And it's, like I said, the only time you're going to see it, if you see Lipid on your medication record, you want to go looking for your lipid panel to see what the triglyceride level was, because I guarantee you it's going to be high. I think the highest one I ever saw was 500 something. That's generally not a good thing. Cholesterol absorption inhibitor, this Zetia or ezetimibe. There were commercials on this a while back. I haven't seen it as much. And this also works in the gut to inhibit absorption of cholesterol in the intestinal lumen. Not necessary to know this, but realize if you give it, it's also given for cholesterol. Vytorin is a combination of a statin and ezetimibe. This is a visual that just shows you the different areas within the liver or within the system that are affected by the anti-hyperglycemic medications. Your nursing process, part of your assessment is looking at your lab tests, your lipid panel, your liver function tests. Right? assessing what current lifestyle habits are, because a lot of what you do is teaching on lifestyle modification, because remember, those are your modifiable risk factors. Okay, it's time for a break.